Hello, we have got Precision Health in the studio today. I'm Dr. Patrick Mullen. I have Dr. Sheena Spielberg and Dr. Ziad Asi. And we were going to talk about bones and hormones. I'm going to quiz them on their favorite bones and everything to do with bone health and hormone therapy. So, with that being said, Sheena, if you want to introduce yourself and tell us your favorite bone.
I'm Dr. Sheena Spielberg. I'm an internal medicine physician with a specialization in women's health. And my favorite bone is the femur because it's so big and strong.
All right. Dr. Asi, do you want to introduce yourself?
Dr. Ziad Asi, board certified in internal medicine, co-owner, co-founder of Precision Health Concierge Medicine in Sarasota, Florida. My favorite bone is the shoulder blade because it's so versatile.
And I'm disappointed that none of you guys said the funny bone. The correct answer today. So I wanted to start out and kind of open up the discussion. So bones and hormones are a very large topic overall. So I feel like we should start with, screening for bone density itself. So Dr. Spielberg, what are the different options of screening and when do most folks start? And I say folks, but it's mostly women that start. And what is your recommendation?
Yeah, there's a couple options for screening. The most commonly used option is the DEXA scan, which everybody's familiar with. Another option is REMS, which is an ultrasound for bone density. And traditionally, the guidelines would tell us to start screening women at the age of 65, but by then, most women already have osteopenia or osteoporosis. So I recommend starting screening much, much earlier, depending on risk factors. That might be in your 30s or 40s. And I like using REMS because we can do it right by the bedside and there's no radiation.
Awesome. So take me through someone's history of bone density. So they're born with over 300 bones, as I recently told you, and the adult body has 206 of them. So as these bones are reabsorbing, combining, when are they their strongest? When do you start losing bone?
Yeah. Okay. So we build most of our bone density when we're kids, young kids and teenagers. So impact and kids who play sports have the highest bone density. And we continue to grow that bone density until we're in our mid to late 20s. And then in our 30s and 40s, there's either a slow decline or pretty steady. And then for women, when they get into perimenopause and menopause, there's an abrupt decline in bone density, a very sharp decrease. There's an increase in bone turnover and loss of bone during that time. And then it continues to decrease, but at a much slower rate. For men, they have a slow, steady decrease through their lives. They don't have that abrupt decrease that women do.
So why do we only do screening at 65? Why not around the perimenopause or menopause period to know what your baseline is?
That's a great question. We absolutely should be. At this point, we're just diagnosing a disease when it's there. It's not, we're not using it, or we haven't traditionally been using it. The medical community has not traditionally been using it as a screening tool. They've been using it to figure out when to prescribe medications for people, essentially. And so we should be doing it much earlier. As I've started to use REMS in the clinic, I'm seeing women in their 30s who already have osteopenia or low bone mass. And at least they have a good hormonal state where they can actually work on it and build it up before they reach perimenopause. So we should be doing it much earlier. Why we wait, I don't really understand.
I think it's medical dogma, right? We all know that medical science doesn't catch up to medical practice for 10 to 20 years for various reasons. One of them is industry standards, testing, safety. This is one of those things that is just really old school. DEXAs were, back in the day, were kind of a big deal, but now you can go to your local gym and some of them have DEXAs. The technology has increased so rapidly that we don't really have a good answer for that. And I think over the next 10 to 15 years, as the rate of information increases and we have the ability to conduct these studies really fast and absorb all that information, especially with as AI comes on board and it becomes accepted into medical literature and universities start using it more and we can rely on it without it hallucinating and giving us bad facts. As long as the data is there and we can absorb it, I really do think that the timeline is going to shift lower. I think that's one of the major reasons, especially as we're doing in our clinic, we're doing REMS, which is bone density ultrasound, that they've been doing it in Europe for years and it is clinically validated. As that becomes more and more available, I think we're going to see, even if it's not paid for by insurance, which usually takes several years before a technology gets paid for by first Medicare and then commercial insurance, it's probably going to start being very readily available on a cash pay basis and then eventually be paid for by insurance.
So I know we've talked a lot about women in bone density in general. We've talked about DEXA scans. Dr. Rossi, why don't you share a little bit about men and hip fractures in general?
I'm so glad you asked me that, Patrick. So men also have hip fractures. 1 in 5 men, their lifetime, will have a hip fracture, and it's the same reason that women have hip fractures. Different hormones. So men's bone density is more receptive to testosterone, and so as testosterone declines, we end up with more osteoporosis in men, and we see this in some young men who have gone through androgen deprivation therapy for prostate cancer, like Lupron. It basically blocks the androgen receptor, the DHT molecule, and so it can't get to the bone to cause that bone density increase. Men usually have a lower risk of osteoporosis because men are the ones that are doing the physical labor, and men tend to go to the gym more, right? You go to the gym it's changed in the last decade or so, but for the most part, weightlifting was a man's thing, and physical labor still is mostly a man's thing, and that's why we end up with less hip fractures in men, because the decrease in bone density, first of all, for men is usually slower, and on top of that, you're having more of that stimulus, whether it's jumping, playing basketball, something like that, or just working physical labor or lifting weights.
And I know personally it's affected us. We have 2 members in the last month that have had a hip fracture, and both of them are men. The data is pretty stark when it comes to mortality after hip fracture. It's, in different studies, between 20 and 25% over the next year that you'll pass away. Not from the fracture itself, but what that represents as a point in your life, being able to no longer be independent, be in the hospital, have to go through rehab. It might signal memory loss. It signals balance or fragility issues as well. So men actually have a higher mortality rate after a hip fracture than women do. So it's important for men to get screened. It's not recommended right now, but it's something that should be done or should be observed, because perhaps they do have lower bone density. We just don't screen it regularly to know that. We don't have the data on it, as you said.
And I think one of the biggest reasons why men have a higher mortality after hip fracture is because they are less prone to hip fracture. So when they do, they're further along in some other disease process, whether it's dementia, whether it's weight loss from, cancer, or any other type of disease. And the frailty has to be much higher for a male to break their femur than for a female to break their femur, just because of the size of men, the muscle mass, and the slower rate of decline. So I think that's one of the biggest reasons why it's usually the sicker men who end up with hip fractures.
So we've mentioned exercise, and you talked about how exercise can be a way to reduce your rate of a hip fracture and your bone density. It can increase over time. So this is a plastic process. It is something that your body can rebuild over time. Talk to me a little bit about exercise and what that means. Are there any studies that are particularly important in this?
Yeah, so there have been a lot of studies on bone density, some of them including exercise, the biggest one being the Lift More trial. And so the numbers are, they're not definitive, and it's a little bit different for everybody. One of the biggest things is impact. So there was a study, it was done in younger people, so it's not as valid for older people. And I think the biggest thing for older people is you do need to be more careful. But it's a measure of how strong you start off. So it's not actually related to your body weight. It's related to how strong you are. So if you think of somebody who hasn't worked out in 40, 50 years and you give them a barbell, that person might not be able to lift 45 pounds. So their 1 rep max is, 45 pounds, and the 80% of 1 rep max ends up being somewhere around 40. So it's like, okay, if you have that person start lifting, it's going to take them longer to get that bone density stimulus than somebody who can lift higher weights. But you always want to take safety first, because you don't want to increase the risk of injury, although you do want them to lift weights. Another one is impact, like I said. So some of the studies showed that anything over 10 inches of drop, so if you think about a curve being 6 inches, add 4 to that, stepping off of that and having that impact is enough stimulus to trigger the bone. And I tell patients this all the time. It's literally any compression, any bending of the bone, because these are the natural forces. And as we're children, which is one of the reasons why we build that bone density is because we're always doing those types of things. We're lifting each other around, we're horse playing, we're jumping off of the jungle gym or, the swing, stuff like that, that will build the bone density. That's obviously not very safe for older people.
Yeah. Dr. Spielberg, what do you tell folks about starting training? So you have an older woman with lower bone density, and she's heard that, if I lift something more than a gallon of milk, I'm going to break my spine. So how do you counsel them around that process of starting to build muscle and do resistance training?
Yeah. So one of the most frustrating things is hearing a patient tell me that another doctor told them that they couldn't lift something or do something physical because I just see their health getting worse and worse and them getting weaker and weaker and less independent because of some theoretical risk of some injury. And yet they're sort of withering away without doing anything. And so when I talk to women about, or anybody about strength training, so one of the biggest studies, or one of the better studies is that Lift More trial that we referred to earlier. And it was a pretty simple study. They took postmenopausal women and had them supervised doing vigorous strength training, pretty basic shoulder press, deadlift, and squats. And it took them different amounts of time to get the women up to speed to be able to do those movements. So one of the things I tell women is supervise. So if you're not used to doing this, you don't know how to do it, you should get a personal trainer. You should get involved with a program that can actually train you how to do this safely. And then you need to go and you need to be consistent. And one of the most important components of it is progressive overload. So you have to have that stimulus on the bone to actually change the bone. And so it can't be, 5-pound dumbbells now, and then in 6 months, you're still using your 5-pound dumbbells. That's not going to put the right stress on your bones to actually cause a change in bone density. So you have to be getting stronger and you have to be increasing that weight as time goes on. That's what it takes to actually change your bone density and improve bone density.
So Dr. Essie, can you say that another way? What is progressive overload and how might somebody program this into their workouts? Is it always I'm doing, 15 reps or pick your favorite number? What does an RPE mean to you?
So progressive overload is essentially as you get stronger, you start to lift more. And it's just a natural progression of lifting. It's obviously much harder in older people for various reasons. One of those is hormones, as we're talking about. So as you age and the testosterone and estrogen declines, especially for women after menopause, those hormones can just completely drop off the map. Or for instance, some women who have their uterus and ovaries taken out, they have next to no androgens except for what's being produced by the adrenal glands. So as it will take them longer and it will be harder for them to build muscle, but with the proper treatment, if we're doing hormone replacement therapy and if we do have personal trainers, and it's very important that that personal trainer is trained in geriatrics. Here in Sarasota, it's not that uncommon to have a geriatric personal trainer. However, you go to a place like California or wherever else where Colorado, where the population is a lot of young people, it's going to be very hard to find that personal trainer that actually specializes in geriatrics. So making sure that the amount of time is taken to recover, eating enough protein, having enough calories in your diet, using body mass analysis to make sure, I guess in an older person, you're not too worried about them getting too much fat. It's not that big of a deal because along with that calorie excess and the working out will come muscle mass, but you need all of that together to be able to get that progressive overload.
So it sounds like you want somebody to have a plan with their health.
It's almost like you would want them to have a plan with their health. It's kind of crazy that doctors don't actually treat this. And as Dr. Spielberg said, you have these women who are afraid to work out and they just wither away. And it's amazing how many of the patients that have come to us in their 70s, 80s plus that are withering away, and we help them with that nutrition, that body mass analysis, the hormone replacement therapy. And they literally tell us, you gave me my life back. They couldn't pick up their baby anymore, the grandbaby. They couldn't push them in the stroller. They felt like they were going to fall over. One lady came in and we literally had to carry her to the bathroom because she was so weak. And after 2 months of working with physical therapy and hormone replacement therapy, she was literally telling me, I got my life back, which is incredible. That all doctors aren't doing this.
Yeah. So as you mentioned, looking forward, and we've talked about balance quite a bit. What are some of the ways in clinic that we can test balance and we can actually predict injury? So the Y balance test and the functional movement screen. Dr. Spielberg, why don't you talk through these tests that we do and what they mean for you?
Okay, so the functional movement screen looks at mobility. It looks at strength. It looks at core stability. and looks for asymmetries on both sides. And those asymmetries are what can lead people to falling or injuring themselves. And if you injure yourself, especially when you're older, it's a whole lot harder to recover. And so you can get very weak that way. Y balance test similarly looks for asymmetries between the two sides of your body. And we know that people are more prone to injury if they have big asymmetries. So we can do both of those right in the clinic to evaluate somebody's movement patterns.
So a couple tests we use in the clinic, Y balance and functional movement. Basically what they do is they tell us how likely a patient is to fall and how far they are from what we would kind of deem as a clinical baseline. So if you're, 15 years old, you can remember me approaching 40. I'm thinking about all the stuff that I used to do in high school that I can't do anymore. And it's kind of crazy to think about because I've been active my whole life and I always look at these old guys and I'm like, I'm never going to be that guy. And so I'm talking to friends my age now and we're like, hey, when you run, have you noticed that you can't keep the same form anymore? Or, you're more stiff in these movements and it's just a fact of how we age, no matter how much we don't want to believe that. And, some people are more flexible than others, but it happens to us, almost to all of us, unless you're very genetically gifted. So when we look at the baseline, it's not an unrealistic baseline. However, when people are in their 70s and 80s and they've been largely unathletic or immobile for a really long time, it's much worse for them. So that stiffness, that imbalance, part of it is because the parts of the brain that control movement, especially in the cerebellum, just like the rest of your brain, as it atrophies, that part of your brain that controls your proprioception and your balance is not as good as it used to be. Part of that is the peripheral nerve, so how you feel in your hands and your feet, and then your ability to judge your body in space. So, for example, break dancers, right, doing the windmills and stuff like that, those are genetically gifted people. Not everybody could do that, and they have certain brains that are able to comprehend that type of movement. If I did that, I would die. So if you think about all of the processes that happen in these old people, these tests, or old people, as people age, these tests are simply just helping us to identify how far off of a baseline these people are. And that gives us a pretty good sense of how likely they are to fall or, not be able to be independent.
Yeah. And I love the functional movement screen and the Y balance test because they are quantitative tests that we can use to assess your mobility and movement. So people always describe, as I get older, I can't do certain things anymore. We can actually put a number on that. And then these are forward looking, something that we can retest against, and we can give you mobility drills and be specific on how to prevent that. Because again, this is one of those symptoms of aging that people talk about, but no one intervenes on. Similar to bone density and hormone therapy, it's undertreated in the traditional medical system. And I love that we look at this and we are very prescriptive for our members.
It's kind of sad because most doctors have no clue about how to treat something like this. They just refer to physical therapy. And it can be as simple as telling your patients like, hey, hold on to a handrail and stand on one foot so you don't fall over, have somebody there to hold you if they're able to do stuff like that. Just thinking about how many patients, can't walk in a straight line, one foot in front of the other. So if you see those things happening in people in their 60s, it's not too late. It's not too late for people in their 70s and 80s. You just have to be much more cautious. But the earlier you catch it, that's the key to achieving this longevity benefit, because you're actually going to prevent it from getting worse as they age into their 70s and 80s, where most of the mortality is.
So, Dr. Spielberg, I know you've seen Dr. Ossie and I playing on the Indo boards in our office. So I love to surf and snowboard and longboard. So I've been practicing balance for a very long time. Take me through your experience on the Indo board and balance in general.
Oh gosh, I am terrified of doing that board because I'm afraid I'm going to fall and hurt myself. I actually really struggle with the board, yet I can
because
surf.
You're a girl.
I can surf. I do, stand up paddleboarding, and the narrower the board you're on, and then you can stand on and step back and turn. I can do all of that stuff. But the Indo board, I really struggle with.
It's probably because you never did it as a kid.
Yeah, no, I never did anything like that as a kid.
So, Dr. Ossie, you mentioned one of the drills that you can do for patients is practicing standing on one foot with a handrail, being able to hold on to something. Being able to grip a handrail is a great segue into grip strength. It's one of the functional tools that we use to measure in a lot of folks. It's another quantitative measure, and it has a lot of association with longevity. So take me through your understanding of grip strength and what it means to your members.
So when I explain it to people in a very practical manner, I tell them, imagine that you fell and you're able to hold on to something and you keep yourself from falling. How valuable is that to you that you're not going to hit the floor and possibly break a bone? And we take that for granted as, people our age. But when you start to see your parents aging and your grandparents, one time me and my wife were visiting Colorado, and we watched a lady trip over the curb and fall and break her arm literally right in front of us. And, we stopped and helped her and called the ambulance. But something as simple as that, if she tried to reach the guy next to her and hold on and she missed. So just that could have saved her from breaking her arm. And so, carrying a bag of groceries, lifting up a grandchild, or let's say a watermelon or something like that, being able to hold on for various reasons. And one of them that I talked about, kind of the cognitive decline, goes hand in hand with the weakness in the quads and the hands. You see it in Alzheimer's and Parkinson's and just general aging. But the grip strength is actually a harbinger. It tells us something, just like a hip fracture, that mortality is getting closer as people are unable to have that grip strength. And it's frailty, it's cognitive decline, it's nutritional status, it's just functional status in general. There's a lot to that.
Yeah. So Dr. Spielberg, we talk about grip strength a lot and it being a marker for mortality. So if you are struggling to open the pickle jar, what does that mean to you?
So grip strength is a good surrogate for overall strength. So that's another reason we use grip strength. So some people think that they just should go train their grip, and that's the only thing they need to do. And overall body strength will also improve grip strength. So there's that important fact with grip strength. But grip strength has actually been shown to be a better predictor of mortality than systolic blood pressure. Everybody's really focused on blood pressure, but the stronger your grip strength, the longer you'll live, and the lower your grip strength, the shorter lifespans people tend to have. So for me, it's a very good marker and it's actually it's a very good motivator for patients. If they are on the lower side, I can show them that, give them a plan, and then we can actually see them progress and get stronger. And we know that they're getting their full body stronger. They're not just getting their grip stronger. And the stronger we are, the more independent we can be for longer, the more muscle mass we tend to have, which is a lot of metabolic benefits, anti-inflammatory, and so forth. So
I just want to say, if you have a high grip strength and high blood pressure, please also take care of your high blood pressure.
Just work on your grip strength.
PSA.
So I love that discussion on grip strength. I always relate it to patients in a way that you are limited by the amount that you can grip to lift up. So if you watch power lifters, strong men, deadlifting in and of itself, they wear grips because the weakest part of their body is their hand. It's one of those smaller muscles. And one of the best ways that I love to tell people about training this is dead hangs, being able to hang on a bar itself and hold up your body weight. It's a very functional movement, and it's also great for decompressing your spine. So I love anytime I see monkey bars when I'm out at the playground with my kids, or I'm at a gym somewhere and there's a pull-up bar. I love to just hang on as long as I can. It's a good challenge for your overall strength. So what are your individual grip strengths?
The best I got to was 90 pounds.
My best or my current?
Your best.
195 pounds, current 165 pounds.
That's weak.
Awesome. So we've mentioned quite a bit about nutrition as a marker. So I wanted to dive into a couple more nutrition topics. So I think the hottest thing in the planet right now is protein. Yes. So the protein shortages, because everyone is getting their whey protein in right now.
That's true. I saw that.
So what is the validated amount of protein that we're looking for our members to eat, and what do we prescribe for them based on some validated metrics? So I'll have you go through, how do you talk a member through their macros and their protein?
So I tell them at least 1,000 grams. I'm just kidding. It's different for everybody, depending on your weight and your muscle mass. So if you have a 95-pound woman who naturally has 65 pounds of muscle mass, and she's strong and she's fit and she's doing just fine, I'm not going to tell her to go eat 150 grams of protein. Based on that muscle mass, she could get away with 70 to 100 grams of protein, and it really is based on individual metabolism. So a lot of people don't need to eat that much protein. However, I eat less protein than Patrick, and he's probably got 20 pounds of muscle on me, so there's something to say for that. But anybody who tells you, oh, you need 200 grams of protein, you need 100 grams of protein, they don't know what they're talking about. We have body mass analysis in the office, so we can literally tell people how much muscle mass they have. And then based on their BMR, we can tell them how many calories to eat. So protein in particular, based on the lean body mass, if you can probably get away with 0.8 to 1.5 grams per pound of lean body mass. That's my opinion. That's what I've seen clinically. People will say something different. That's perfectly fine, but that's what I tell patients.
And Dr. Spielberg, what do you tell folks about their protein requirements? Is it as much as they can get per day, or is there any specific formula or way that you go about prescribing this?
That's a good question.
I guess there's one thing to think about. A lot of women do tell me it's very hard for me to eat that much protein. You know, if you get a whey protein shake, it's usually 25 grams of protein. A block of firm tofu is 40 grams of protein. There's like 90 grams of protein in a pound of 93.7 ground beef. Chicken breast, depending, how many is it? How many ounces is it? 40? I think it's 4.
Yeah.
4 ounces of raw chicken breast is 40 grams of protein. So for the women that have difficulty getting the protein in, a lot of times what we do is we set a goal and then we just say, hey, how much are you able to get? Keep a food log for 2 weeks and then really go down the line and say, okay, are you the type of person that's always eating sweets? Is that where your calories are going? Is it just a lot of carbs like rice? What is it for you? And so one of the things I tell my patients is beans are a great source of protein and fiber. And just as far as a healthy diet, there's a lot of benefits, including the antioxidants, et cetera, but they make you full. So for a lot of women, it's hard for them to get all their protein from beans. For me, it's not hard at all because I can eat as much as I want. So usually for men, it's not that big of a deal. We tell them have a couple protein shakes, eat some chicken, tofu, or beans. And then for women, the key is really figuring out how much they can eat, because a lot of times, like my wife in particular, it's dictated by appetite. It's hard for her to get the total amount of protein because she just can't eat that much.
I'm telling a lot of women too to spread it out throughout the day. So, usually somewhere around 30 to 40 grams, depending on what their goals are for the day, but spread out 3 or 4 times throughout the day. Because I have a problem with a lot of women just not eating, or, breakfast might be a piece of toast.
Especially
and then,
as they get older.
Mm-hmm. And so trying to shift what they're eating to higher protein sources and to ideally more nutrient dense sources. So especially with breakfast, a lot of people can't get enough with breakfast. And so trying to get more with breakfast, and then trying to get some after their workouts as well. I know there's some debate about, the timing of protein, but we want that muscle protein synthesis to happen after you're exercising and after you break down that muscle. So 3 or 4 times a day, getting a big dose of protein, that's what I set out for most of my patients.
Yeah. I love that you mentioned whole food nutrients, because it's not just all about the macros. This is not a dirty bulk all the time. We care about the quality of the nutrients, the micronutrients that go with that. So as a segue, what do you think about micronutrients and minerals and vitamins when it comes to your bones? So vitamin D, magnesium, and calcium are very much talked about. Take me through your approach around these micronutrients.
Yeah. So for calcium, for bones, there's a few different nutrients that have been studied that can help with bone density and help improve bone density. So for calcium, I'll start with calcium because that one's a little bit more controversial. Ideally, you should be getting calcium through your diet. And so I tell my patients that it can be hard to get. It's about 1,200 milligrams of calcium that you want per day. Ideally through diet and not through supplements, because with supplements, there may be an increased risk of kidney stones. There's some question, is that going to increase calcification in the arteries? That's a debatable topic. But for the motivated patient, I can have them keep a food diary, and I can see how much calcium that they're getting. And usually we can make some dietary changes just to achieve those goals without having to supplement. But getting enough calcium is important for bone density. Vitamin D. So for most women, I'm shooting for a vitamin D level of 50 to 70. And I'm going to check their levels. So the amount that I prescribe is going to be based on their blood work and not just a number. K2 is another important nutrient for bone density. Strontium, boron, collagen, particularly for-to-bone collagen, has also been shown to improve bone density. So those are, and magnesium as well. So those are the big supplements I have in my stack to give my patients with low bone density.
I love it. And Dr. Spielberg, you mentioned specifically that you are checking the levels of vitamin D, and you didn't even mention a dose for a lot of these things. So, Dr. Rossi, take me through what is personalized supplementation and why we don't make generic recommendations for most folks and we're testing actual levels. We look for outcomes.
We have the ability, I want to call it a luxury, but really it's not a luxury. It's a choice that we've made to have this available to our patients. So for them, it's a luxury because most people don't have this available. But we have the ability to actually test micronutrients. We have the time, we take the time to test micronutrients to make sure that we're not just giving our patients random amounts of supplements. We don't just take something off the shelf and say you're good. We actually test what their levels are, and then we can create our own supplements based on those levels. So we have a manufacturer in the United States, quality standards that we know we're getting pure supplements. There's no contamination. So a lot of people want to say the supplement industry, which is completely true. Half the time you're getting a fake supplement. It could be tainted because who knows which country it came from with their quality standards. And then also the companies themselves are just marketing it to you. So half the time you're not getting what you're actually paying for. We know we have lab testing showing that's what we're getting, and we provide that to our patients, as well as some other trusted brands that we have access to. And so by being able to take the time to test the the nutrient levels, the different B vitamins, vitamin D, zinc, magnesium, we can see those levels in the blood. And, you, for example, have to take 5 times as much magnesium as I do to get the levels. Just like some patients I have them, we can't get their vitamin D level up, and we're putting them on some pretty significant doses. So literally, if you're just taking something off the shelf, God knows if you're getting the right amounts for you, you actually need to have your levels tested. That's the best way to do it.
I love that. So one size fits none, and it's very much outcome oriented, and it's constantly changing and evolving for our patients based on what they eat, how they evolve over time. So I want to shift gears a little bit. We've been talking about building bones and what happens through a natural process. So let's get into some of the engineered things that we in medicine can prescribe to increase or decrease bone density. So the first of these topics is GLP-1s, everyone's favorite peptide that you can get online from the same doctor that prescribes your ED medicine. So, Dr. Spielberg, what is your take on GLP-1s for bone density? Are they the best things in sliced bread, or are they going to kill everyone?
So GLPs are great for weight loss, great for improving metabolic health. But if you're not holding on to your muscle mass during that time, you will see losses in your bone density. So we will see more osteopenia and osteoporosis. But interestingly, people, when they do lose that weight, they can move more. And if they're willing to, and they're willing to make sure they're getting enough protein and willing to strength train, then we won't see those bone losses. We won't see those muscle losses. And so that's why we do the in-body scan, so we can keep an eye on it and we can go slow with their weight loss. So it's great for a lot of people, but I've also seen people who've just been thrown on it, put on really high doses. They lose, 80 to 100 pounds. They're getting it online. They've not really been doing any of the nutrition piece of it. They're just not barely eating anything. And they lose a ton of muscle mass. They become weaker and they lose bone density. So depending on how you use it, if you use it responsibly and you have a plan for it, then it can be a great tool.
Yeah, the answer is that you don't want to lose weight as fast as possible. I tell my patients slow and steady wins the race. Slow and steady is the key to making it work. And sometimes you don't even need to lose weight, because if you're working out and eating right while you're on the GLP-1s, because I have a lot of patients who are metabolically active. They have a little bit too much fat. Maybe they have some visceral fat, but they also have a lot of muscle mass. Those are the patients who tend to do the best, because their body, the insulin sensitivity goes up. They're able to use the nutrition better, the protein that they're eating, and they're still working out, and they have the best results because they usually maintain muscle mass, and we don't lose that much weight. Maybe we lose 15 to 20 pounds, depending on how they started. The people who are eating, pizza and chips and have a really bad diet, those are the people that do the worst on the GLP-1s, because they get next to no nutrition and they continue to eat those foods. They're not eating whole foods. Everything they're eating is highly processed. If you're eating Oreos and chips and whatever soda, you're going to have a horrible result on the GLP-1s. You're going to lose weight. It's just going to be mostly muscle mass and some fat. And a lot of people actually end up with a higher body fat percentage despite having the weight go down. And that's the worst case scenario. And we see a lot with these online pharmacies, Hims, Hers, whatever else, because these people are not being actually monitored. They're just getting the drugs. And then the crazier one is, the people that are getting it from the gym. God knows what's in it. I can tell you it's probably not retatrutide. It's probably some other drug in there, whether there's any GLP-1 at all, or if there's anabolic steroids, nobody can tell because these drugs are not tested.
Yeah. And I always struggle with using weight as a metric. I hate to say weight loss medicines. And what we love to do here is body composition remodeling. I saw a member this morning. He's been on a GLP for about 8 months with us. He's also on hormone therapy, and he's on a prescribed nutrient regimen. He lost 7 pounds over the past 7 months, and his muscle mass increased by 6 pounds. So his body fat percentage remarkably dropped, even though the scale didn't move that much. And that's the most important part. Number one thing that I love to hear from him is his joint pain's improved. So increasing muscle mass, decreasing total load on your spine is really helpful for those joint pain problems.
And I think the most dramatic thing we see with the GLP-1s is the decrease in the visceral fat. So fatty liver, fat around the heart, fat around the kidneys, that visceral fat is actually now proven to cause inflammation and disease. So by putting people on GLP-1s, we've seen their inflammatory markers come down dramatically. And when they get on the in-body, it's on a scale of 1 to 20. Over 10 is considered bad. We have some people coming in 18, 19, and after 7 or 8 months to a year on these GLP-1s, I've watched their visceral fat whittle down to 4, 5, and 6. And those people are the ones that get the best results.
I also love pointing to a population study in Denmark, since Novo Nordisk is based in Denmark and they're a pharma economy driven. A large proportion of their population is on the GLP-1, and they've done long-term validated studies looking at DEXA scans to see bone density and muscle mass in patients. Those that are on GLP-1s and work out had no change in bone density. Those that are on GLP-1s and did not work out had the largest decrease in bone density. So it's not that the GLP-1s are good or bad. I like to tell people they are tools. It depends on how we use them. They're powerful tools though. And sometimes that's not what needed for a small body composition change.
That's why you don't use a pickaxe to chop your fingernails.
Well said. So I want to change gears and start talking about hormone therapy. I feel like this is a very hot topic. The FDA just sent out some new guidance on estrogens. So Dr. Spielberg, what should we know about the background or landscape of hormone therapy in America? Why is this so controversial?
So everybody got scared of hormone replacement therapy after the Women's Health Initiative study came out in 2002, I think it was. And it showed that there was an increased risk of breast cancer and an increased risk of strokes. And at that moment, everybody stopped taking their hormone replacement therapy. Doctors stopped prescribing it. And then we have this, generation of women who it wasn't even an option for them. And so looking back, the data's been scrutinized, and looking back at it, what it showed does not apply to the way that we do hormone replacement therapy now. It showed there was a 1 in 1,000 increased risk of a diagnosis of breast cancer in women who took a synthetic estrogen and a synthetic progesterone, which we don't even prescribe anymore. Women who just took estrogen without the progesterone actually had a lower chance of breast cancer than women who didn't take anything. And so this scare on breast cancer actually, it was really overblown. And then, you fast forward and we've got women now with osteoporosis and osteopenia, and you can look at the mortality rate after a hip fracture, which is higher than the mortality rate from a diagnosis of breast cancer. That study, those results were not valid for the way that we prescribe bioidentical hormone replacement therapy now. The increased risk of stroke, that was also with oral estrogens, because of the way they're metabolized, they have these byproducts that can increase clotting risk. And so we rarely use oral estrogens anymore. We're using, through the skin, so patches, gels, we've got, sublingual pellets, things like that. So there's a lot of other ways to deliver hormone replacement therapy. So those results that really scared everybody really aren't valid to the type of medicine that we're practicing now. And we know hormone replacement therapy decreases cardiovascular risk, decreases cardiovascular mortality, decreases colon cancer, decreases risk of diabetes, and then of course the osteopenia and osteoporosis. So there's a lot, and maybe a decreased risk of memory loss and dementia. That's on being studied. But we were scared of this one diagnosis, breast cancer, and so instead women developed a lot of other health problems that they didn't have to have.
Yeah. So it sounds very much like a traditional medicine reactive type moment of we get a study, we form an abrupt reaction, and we change course instead of forward thinking for the long term and thinking about patients first throughout their lifetime rather than diagnoses and codes for insurance companies.
Mm-hmm.
I had one patient, 63 or 64-year-old, and we were discussing this topic, and she had already completed menopause, and she had asked her doctor for hormone replacement therapy, and he wouldn't give it to her. And her exact words were, "Damn it, give me the hormones. I'll take the increased risk of breast cancer, the tiny increased risk of breast cancer." And, just like you guys said, the different things that happen as women age without estrogen, all of the things that we can prevent. If we save, 1 out of 10,000 women from, some risk of breast cancer that may or may not exist versus what we do know about UTIs and dementia and bone density and all of these other things and just their overall well-being, because a lot of women after menopause truly do become miserable. They will tell you that just the increased quality of life that you have from the hormone therapy, because it's not just about sex. I had a doctor when I was discussing with him tell me, "Oh, so grandma can have sex again." I'm like, dude, I don't know what you're talking about, what type of education you've had, but you're way behind on the literature. That's not what it's about. It's about everything.
Yeah. And I think speaking to the literature and how we were trained, again, with the Women's Health Initiative, it scared many doctors from prescribing this, and it was not taught in medical school. This was something that was a foregone conclusion and was not a typical part of training. So again, how did you upskill yourself on something that's so important? And where are the best places to learn about validated hormone therapy, not back of the napkin or symptom-driven hormone therapy?
Yeah, so it's interesting. So not only were we not taught about it, but residents and medical students are still not being taught about it. It's still not in their curriculum. I was just speaking to an internal medicine resident just in the past few months, and they treat hot flashes with gabapentin is the way they do that, and that's all they're taught. They don't do any hormone replacement therapy. So I've already forgotten the question because I was so excited to say that.
Where do you get the good information?
Yeah, the good information. Yeah, that's so I read I just started reading. So it was about 4 or 5 years ago, I would say. I'd been prescribing it longer than that, but I really got into the literature and really started to not just prescribe it, but recommend it, because I was prescribing before, and mostly to treat hot flashes and treat some of those symptoms, but to actually start recommending it and saying this is something you actually should be doing to improve your health, not just to treat a symptom, was about 4 or 5 years ago. The Menopause Society was a great resource for me when I was going through it, and then I just started reading studies about the benefits of it and the risks, and so I knew for myself, and then I started prescribing it, troubleshooting when there was an issue, and I went from there.
Okay. I just had a flashback to med school. I don't know if you remember this, but we were told they could do estrogen. I think it was 1 or 2 years after menopause and no longer than that. Do you remember being taught that?
I was taught that. I was taught that at some point.
And I don't remember what their reasoning was. I think it was the increased blood clot risk and whatever else. But I started looking just at validated studies from large medical institutions, Harvard being one of them, because I know that they're not going to have an agenda. They're going to be presenting what is known. Sorry, what's the word I'm looking for? What is thought to be the truth, because that's what research is. We're trying to find the truth in the data. And so if you look at it objectively and you kind of take out the stigma, or you take out the agendas, you can look at the data yourself. And sometimes you can read a study and be like, I don't really agree with that conclusion, which is how we're supposed to be trained as doctors. Unfortunately, most doctors are just blind followers now. They follow whatever the American Medical Association tells them, despite, there being evidence otherwise, many times we see those reactions from doctors, and we're not supposed to do that as doctors. We're supposed to take the time to educate ourselves and be up to date. And I think that's the biggest difference between a good doctor and I'll call him a regular doctor, is actually taking the time to research.
I also just want to, another story from residency was residency in medical schools. I remember having women in their 40s as patients, and there was some derogatory term that was thrown around, like a whiny woman or some. No, it was like they had these vague symptoms. They were tired. They can't sleep, and I remember not knowing what to do and just going, oh, this is like, what am I like? Oh, geez, like what am I supposed to do with this? And male attendings, female attendings, nobody knew what to do with this. And then you fast forward, and again, when I started really getting into it about 5 years ago, the same women are coming in with the same complaints, and now I have the tools. I can get them adjusted on hormone replacement therapy and change their lives in 3 months. So that was the most rewarding thing for me, and why I just got more and more into it, because I'm like, I can help the majority of these women feel better. The joint aches and pains that never get talked about, the musculoskeletal syndrome of menopause. They get worked up for autoimmune diseases, and they're like, oh, you're just getting old, and you can start a little estrogen and all their pain is gone. I mean, it's just, it changes people's lives. And that's why I really got just more and more into understanding as much as I can about it in every aspect of it. And I'm still learning about it. I'm still learning from my patients as they go through experiences with it too.
It's kind of crazy because we're living through the golden age of perimenopause right now. Yeah. This type of stuff that we're talking about, talking about AI in the past 2 years, it's like, well, thinking about the advances in medical care in the past decade, we've come pretty close to curing diabetes at this point with the repertoire of drugs that we have available to us now. The stuff that we're doing in hormone therapy, men's hormone therapy. We learned in medical school that testosterone increases the risk of heart attack and stroke, only to find out that's not true. Overdosing testosterone does. And so now as the data comes about, as more people are being treated and we have good data and reliable literature, we're able to, either debunk or prove some of this stuff that's happening. And we don't have an agenda. We're not trying to sell everybody hormone replacement therapy. We're treating the people that get benefit from it. And we're going where the research leads us. That's what we're doing. And that's what medicine is supposed to be about. It's supposed to be about finding the truth and helping people.
Yeah, I love your use of evidence-based therapies and being able to independently interpret some of these studies. Remembering that all of these studies are population-based. We get bands of normalized individuals. And this goes along to your comment on stopping hormone therapy at a certain age for women. And this was just a cohort off of the study. We have to remember that people are individuals. They don't just turn a certain age and all of a sudden they were another human being, right? Women in their 40s all of a sudden don't become the whiny women that are derogatorily referred to in medicine. And same idea when a woman turns 60, it's not, well, this is the end of your hormones. We're going to remove these now. Everyone lives an individual lifespan. And this is where personalized medicine and precision medicine, callback, is going to be utilized in the future. So I love that we're on the cutting edge of a lot of these things. We've mentioned the withdrawal of hormones for a lot of women for a generation, and things are just now starting to turn. On the other hand, Dr. Rossi, testosterone seems to be on every street corner, and you can get it from your house cleaner and online and the same place that does your Botox. So talk to me about testosterone replacement therapy. What's safe, what's indicated, who should do it, and who shouldn't?
My favorite testosterone therapy stories are, I take this back, the worst testosterone replacement therapies that we get are women who come to us after they've gone to one of the HRT clinics. If you think that HRT is a silo, if you think that it's one thing that you're going to do and you're not going to treat the rest of the person, that's the first sign that your doctor sucks. That's the first sign you need to run away from that person. You can't just go somewhere for HRT. That's absolutely wild to think about. As we've talked about all the other metabolic things, we have these women that come to us and the doctor tested their hormone levels several years ago and just kept giving them that same amount. They didn't check the red blood cells. They didn't check the actual hormone levels. They didn't check anything, not muscle mass. And so you have these people that have been on the same hormone therapy for years. It works for a lot of people, but you still need to check at least every 6 months. The most dangerous ones are the ones that come in with really high testosterone. And it doesn't usually take very long. It takes 4 or 5 months before they start to see, their voice changing and masculinization because they way overshot that testosterone. In the hormone world, less is always more. We always want to start with the minimum that will work. It's not a race. We're not racing to get your hormone levels up. What we want to do, slow and steady wins the race always. We want to start with a dose that we know for most people based on their body weight is going to get them to the lower end of the range. And here's the thing. Just because you're on the lower end of the range doesn't mean that you won't get the benefits. So for instance, about 6 months ago, I inherited a patient whose doctor kept her testosterone at 125, and she'd been like that for 4 or 5 years. And she's like, yeah, I got these little chin hairs. I said, well, why don't we take you down to 75 and see what happens? We kept her at 75 for 3 months. And I was like, do you feel any difference? She's like, no, but the hair went away. I said, okay, let's drop you down to 50. At 50, we did her in body. And after 3 months at 50, her muscle mass improved. And this was a lady that was already fit. Her muscle mass improved and she felt better than ever. So did she need to be at 125? No, it was a complete waste. And it actually increases the risk of side effects to be at a higher dose. And so guys come in, they're like, oh, my other doctor kept me at 1500. I was like, yeah, but your red blood cells are also really high. You have high blood pressure and you can see the changes in your face. So if you want the increased risk of heart attack, we can keep you here, but I can almost guarantee you that I can take you down to about 900 or even 700. And then you're going to still have the benefits and you're not going to have the side effects. You got me ranting, Patrick. So testosterone is one of the most overprescribed, not by numbers, but by number of people, but people who actually are on the testosterone, they're getting way too high doses of it. Their doses don't need to be that high, and it's very nuanced. People don't want to believe this, but the higher you go, it's risk reward and it's diminishing returns. So if you're peaked at 700 and you go up to 1,000, you're going to have almost no more benefit, and the risk of side effects are going to increase exponentially. Who shouldn't get it? People who have prostate cancer. For women, it's not breast cancer. Most of the time, it's not testosterone receptive. However, there are very few women who are. So if there is any history of breast cancer, that's something that you want to go very lightly on that.
Yeah. So I love when you explain that if you go to somewhere that only does hormones and exists in a silo, that's one sign. I feel like another sign of poor hormone therapy and one of the bad raps that hormone therapy can get is if they do only one method. So if you go into your doctor and you get the same hormone special that everybody leaves, just like the plastic surgeon, where the front desk and the nurse and everyone else who leaves the office has the same size implants, that's a sign where your doctor is the one prescribing, and you are not the one having a partnered relationship with them. So, Dr. Spielberg, take me through the different tools that are in your tool belt, as you mentioned, learning hormone therapy. What are the different avenues and routes that you can do to treat hormones? It's not just one size fits all.
Yes, I'm glad you mentioned the choice, because that's what I wanted to rant about when it comes to these hormone clinics, is that they don't offer choices and there's a lot of options, and I don't think they even understand how some of it works. It's just that this is the only way to do it. I have so many people coming in, so many women coming in and men that were only given this is just what you do, and their levels are all over the place, and they have different a variety of symptoms. But yeah, there's options. So there's for estrogen, there's creams, there's patches, there's troches, there's pellets, there's vaginal inserts. There's a whole variety of options. For testosterone for women, you can likewise do pellets. You can do troches. You can do creams. So we have a lot of different ways to deliver hormones that we can individualize to each person. I have ways that most people like and that I may start with, but we always go through what are somebody's preferences, what is their lifestyle like, and then we can individualize it from there. And if we try one method and maybe they have side effects like patch, some women will get some itchiness or something like that, or they fall off, we can easily switch to something else. So we have a lot of different ways to deliver hormone therapy.
And I think that's one of the issues with standard primary care doctors is they don't understand that there are ways to get different formulations. And so they just prescribe whatever's available to them, half the time not knowing whether it's the right dose or not. And they don't have the correct follow-up, because when you have 3,000 patients, it's really hard to keep up to date on your patients on checking their levels every 3 to 4 months or even 2 months until you get them optimized. They can't call you and say, hey, I'm having these symptoms. It's going to take them 2 or 3 weeks to get in. And by the time they're there, their hormone levels are already way off. So one of the things that people talk about, right and wrong, is compounding pharmacies. So just like there are good doctors and there are bad doctors, there are good compounding pharmacies and there are bad compounding pharmacies. And the FDA has cracked down quite a bit on compounding pharmacies. So a lot of the smaller ones, even though they weren't bad, they just were small. The FDA kind of wiped them out. And there are several very large compounding pharmacies that have decades of experience and levels of trust that we know we're going to get really good results from them. One of the ones that we like to use in Tampa is a massive compounding pharmacy called Strive. And there are a couple of other local compounding pharmacies that we like to use because we know that we're going to get high quality products from them. And we know that the compounding is going to be correct. So just because it's from a compounding pharmacy doesn't mean that it's bad. You have to know where you're getting your prescriptions from, and it allows us infinite customizability on what we want to do. The only thing we're bound by is physics, right? You can't put 1,000 milligrams into 100 milligrams of cream, or else it's just powder. But we can adjust as much as we need by how many pumps they get, how much is in each pump, as well as the different methods, whether it's pellets or troches or whatever else.
I'll also mention too, some people think that they can only get hormones from compounding pharmacies because that's the only place that does, quote unquote, bioidentical. So bioidentical just means, chemically similar to what we make. And the FDA approved versions there's plenty of bioidentical options available there.
Everything that we get now is bioidentical.
Everything is bioidentical.
Everybody wants to use that as a marketing term.
Yeah, so we could use compounding pharmacies for that. We can use a regular pharmacy for that. We've got all the tools to use it in either place.
Yeah, I just mentioned the compounding pharmacies because they allow us to customize versus what you can get from the pharmacy.
Yeah, I love that. And that's why there's so much nuance when it comes to hormone therapy. I always like to guide patients first. I tell them the route of delivery is up to you. What's most convenient, what works best in your schedule. And I'm adaptable to dose it to get to our goals based on that. So you tell me how you want to get the hormones delivered, and then I will work with you to make sure the dose is to the correct level. So we know, as Dr. Rossi talked about with the Traverse trial, that there are safe limits for testosterone in men, and there are goals that we would kind of track and monitor no matter which way you choose to dose it, whether it's injectable, it's topical, or it's pellet therapy. Those are some of the most common versions, but there are more than that as well. So Dr. Spielberg, for women's hormone therapy, are you looking for their estrogen levels to get to 30, 60, 100, 1,000? What is the research showing that for bone density, and how do you dose based on symptoms?
Yeah. So for estrogen, I'm looking at both symptoms and I'm looking at protecting bone health. And so in the literature for estrogen, so first of all, the higher the dose of estrogen women are given, the better their bone density. And that's regardless of what estrogen levels are. So the higher the dose, the better bone density. But not all women can tolerate higher doses due to symptoms from the estrogen. So I'm also looking at estradiol levels. So usually above 50 is where the literature sits. It's going to help with bone density. And if you get upwards of 70 or 80, you're going to have a little bit more of an effect. So for me, at the very least, I'm going above 50 if I can. And if I can get that closer to 70 or 80 and somebody's tolerating it, then that's what I'm looking for. And then I do want to get rid of their symptoms. So hot flashes, improve their sleep, make sure they don't feel like they're losing muscle mass or getting pudgy. We can kind of help estrogen with that. And then also avoiding symptoms. So breast tenderness, bloating, and like lower abdominal pain I can see sometimes with estrogen.
Yeah, so it's very much a balance of those two. It's not 100% focused on symptoms. It's not 100% focused on levels. In women, we have to balance both the estrogen and progesterone. So talk to me about uses of progesterone, ways that you dose progesterone, And then testosterone would be that last kind of sprinkle on top.
Yeah. So progesterone's primary role is to really prevent the uterus from overgrowing and preventing endometrial cancer. So if you have a uterus, you have to use progesterone. And so we need at least, if somebody's on estrogen, we need at least 100 milligrams of progesterone. And there's a variety of ways to do it, but usually it's between 100 and 200. We can go up from there. If you start getting breakthrough bleeding, we might go up on the dose. Progesterone's also great for sleep and helping with sleep and helping a little bit with anxiety. It may also help with hair growth. So I'm generally using progesterone to balance symptoms. But if I'm starting to get women on higher and higher doses of estrogen, and if they have any breakthrough bleeding, I'm going to go up on their progesterone as well. And then testosterone, I get the estrogen and progesterone dialed in, get symptoms under control, and then I use testosterone really only when I need to for specific clinical purposes. So a big one is libido. But for many women, you can get them there with estrogen and progesterone because they're getting better sleep, they're feeling better, and then the sex drive improves as well, but not for everybody. And so then I will sprinkle on some testosterone based on that symptom. Or if somebody's lower bone density, they need to work on muscle mass, they're sarcopenic, then I'll add some testosterone to help with muscle mass as well. That's how I generally use it.
I think we forgot to mention about the falls. The higher muscle mass actually acts as a pad. So that fragility, which is another reason why hormones are good for preventing fractures, is because the more muscle you have, the more stable you are. And if you do fall, it literally acts as padding to prevent the bone from breaking.
Yeah, I love that. So speaking of fractures, the last thing that I want to cover today is the use of medications or other augmenting strategies to help with bone density. So we've talked about diet, we've talked about supplemental things, we've talked about exercise, we've talked about hormones. So what are the actual pharmaceuticals and what are their roles when it comes to bone density?
Yeah, so this is another place where I see women not given a lot of choices when it comes to what they can use from a pharmaceutical standpoint. But our pharmaceuticals are the most effective tools we have to improve bone density. Most people are only offered bisphosphonates. So that's like Fosamax, for example. Alendronate is the most commonly prescribed medication for bone density. And they are great medications. Those help prevent bone breakdown. They do not necessarily help build new bone, but they do help prevent our bones from, our body from removing excess bone. But they do have some side effects. So osteonecrosis of the jaw like the rotting of the bone jaw is the scariest one that's out there. It's very rare, but I've seen cases of it. So it's a known side effect of the medication. Atypical femur fractures after somebody's been on the medication for a really long time, then you're actually interrupting the bone's natural process, and that can make you more likely to fracture. So we have to keep an eye on how long somebody's been on it. But we've got other options as well. So some of my favorite ones to use are Evenity. Tymlos is another one, and these are anabolic agents, meaning they actually stimulate the cells to build new bone. And Evenity is kind of cool because not only do you build new bone, but you're also blocking those cells that are removing bone. So you can see big improvements in bone density and bone quality with Evenity. So that's one of my favorite ones to use. I'm very limited because of insurance. A lot of times insurance have very specific requirements for when you can prescribe it. So you have to have really low bone mass before insurance will approve it in a lot of situations. So I'm more often, unfortunately, guided by insurance choices than I am by the medications that I want to prescribe. But I want to, if I can use an anabolic agent to actually build more bone density, I'm going to start there. And then if I can use strength training, hormones, and nutrition to help them hold on to that bone density, once I stop one of those agents, because you can only use them for a certain period of time, I may have to switch them to something else, depending on the kind of improvements that we see, or we might be able to just do hormones and strength train and just keep an eye on it. But regardless of which tool we use, we got to check and see if it's working. And we do that with blood markers. We do that with, bone density ultrasound, the REM scan, with DEXA scan. So whatever tool we're using, we're going to check and make sure it's actually working.
So I love Evenity. I love a 2-for-1 special, or Publix BOGO. So Dr. Rossi, one of the 2-for-1 specials that we use for a limited population are some older anabolic steroids. So talk me through when that might be a good use case for bone density and sarcopenia specifically.
Very specifically, it's in older adults and very old adults. So if they're not under 70 years old, for the most part, I'm not going to use them. If they have had a history of prostate cancer, especially metastatic. So there's a lot of interesting research in prostate cancer right now about androgen levels. And I think over the next 5 or 6 years, we're going to have a paradigm shift in that prostate cancer treatment. But for now, with the evidence that we have, definitely stay away from them. But specifically people over the age of 70 that have frailty, so really low muscle mass. If they're telling me that I can actually watch them in the clinic when they're getting out of a chair and struggling to use their quads to stand themselves up. We can take those people and within 3 or 4 months watch their muscle mass dramatically increase. And we actually have a really large amount of data on stanozolol in particular because it's used for a very specific use that's FDA approved for hereditary angioedema. And so at the doses that can stimulate muscle mass on a lower dose for older people, even in children, there was shown to be no negative effect on the HPTA, which is the hypothalamus pituitary axis, which is how we gauge, what we call shutdown when your brain tells your body to stop producing androgens. That's not an issue in these older people because guess what? Their HPTA already did that. So they don't have any hormonal imbalance other than really low hormones. And so we're just bringing them up. And if you dose them appropriately, you have next to no side effects. And appropriately means at a low enough dose and not for too long. So for the most part, what we do is we check their liver enzymes, and we do that once a month. And then we have them come in and they do the in-body scan. And so we don't usually, unless they're in a really dire situation, which I had a lady who was discharged from the hospital. She got readmitted. She got sick twice. And by the time she came out, she was so weak and frail. She could barely stand up. And within a few months, we had her back on her feet and back to her normal life. And so those women in particular, I had another lady who had a stroke. She withered away in the hospital for a few months. I couldn't see her because she was actually traveling when she got sick. And then by the time we got her back, I tried one anabolic steroid. We didn't have that good of a result on stanozolol, but oxandrolone worked wonders for her. And literally, we had an 87-year-old woman gaining 10 pounds of muscle mass, which is nuts. I would love to gain 10 pounds of muscle mass. But the part of the reason why was anabolic rebound, right? Her body had lost that muscle mass, so it helped it build it back. It wasn't all new muscle. But that lady, we probably bought her 4 or 5 years more because she was on her way out if we didn't do something. And other doctors will listen to this and be like, oh my God, he's giving old women anabolic steroids. How dare he? We have a lot of data on these from burn patients, from HIV patients, even from children. So I know for a fact that I can use these drugs to benefit these people. And it's like, I've literally saved people's lives with them, which, we're using our brains as doctors. And I'm telling the patients, hey, these are the anabolic steroids that were used in the Olympics in the 60s, like stanozolol. And, there are some risks of X, Y, and Z, especially for women, which is masculinization, which we avoid if we use it at a low enough dose and don't use it too long. And also the liver issues, which we have proven otherwise, at a low enough dose, there are no liver issues. And on top of that, they increase bone density, which we have evidence of that from hospitalized patients that were on these drugs in the past. One thing is I believe oxandrolone did recently lose its FDA approval, but the evidence doesn't change.